Good morning, everybody. Welcome to this online CME series being conducted by the Kerala Society of Ophthalmic Surgeons. Today it is the 14th in the series, and today we have Dr. Swapna Nair, Senior Consultant, Cataract and Refractive Services, Chaithanya Eye Hospital and Research Institute, Trivandrum. She is a renowned speaker at national and international conferences, has received numerous awards. Her area of work is adult and pediatric cataract surgery, flax, LASIK, phakic IOLs, anterior segment reconstruction surgeries, femtosecond corneal lamella surgeries. Today, she's going to tell us how one can become a Whizkid of biometry for cataract surgery. You all know if you're wrong with your biometry, you're going to land up with refractive surprises, and it will be, even if you do a wonderful surgery, finally you will not be satisfied with the outcome. So before we go to the talk, I request our president, Dr. Meena Madam, to say a few words before Swapna takes over the platform. Over to you, Madam.
Thank you, Rajiv. Good morning, everyone, and welcome Swapna to the Zoom meeting conducted by KSOS. She is speaking on a very relevant topic in an era where the bread and butter of the cataract surgeon, the routine cataract surgery, has been elevated to the status of refractive surgery. The visual rehabilitation of the patient, a perfect visual rehabilitation, is very, very important, and hence ocular biometry is one of the most important aspects of the patient achieving a good refractive correction. With these few words, I wish all of you a very happy meeting, and over to you, Rajiv.
Thank you, Madam. Swapna, can you share your presentation and take over the platform?
Thank you, sir. Thank you, Madam. I think you have laid the background for what I'm talking about. And like Ma'am said, it's a very relevant topic, especially because cataract surgery has ceased to be just removal of the cataract. It has become more like cataracto-refractive surgery. I hope you're able to see my screen properly.
Yes.
So here, my aim is not to teach how to do biometry or elaborate on the various methods of biometry per se. I'd be dealing with all that, but it's basically how to deal with situations where you get variable biometry or where you're in doubt as to what method to choose or how, why would you like to transition from one method to another. So all of you know how to do biometry because it is an essential part that not only the optometrist, but the ophthalmologist himself or herself knows the various parameters that you're trying to measure, the different types of eyes that are going to be measured, and why you need to choose certain calculations over the other. Now, there always has been an age-old debate in biometry, whether the olden practice of ultrasound biometer is better than the newer one of optical biometry. Now, ultrasound biometry undoubtedly is the very cornerstone of ocular calculations. That is the method by which we started implanting intraocular lenses into the eye, providing good vision to the patient. Because when Harold Ridley implanted his first intraocular lens, he was off by around 23 to 24 diopters, myopic. So he did take the cataract out and put in lens material, paving the way for future IOL implantations. But I'm not sure that the patient was very happy with the result. So now what we're aiming to do is to provide bang on accurate values. You cannot afford to be off by 1 diopter in 90% of the cases. You have to be within 0.5 diopters in 95% of the cases. So that is the level of accuracy we are aiming at. And of course, so do you want to use a conventional biometer or an optical biometer? By conventional, I mean ultrasound. So this is the basic debate between contact versus non-contact or light versus ultrasound biometry that we are also talking about. Now, contact biometry, either by applanation or by immersion, is very, very relevant even today. First of all, because it's more accessible. So you And it is pretty much accurate. It is pretty much accurate in a lot of eyes, whether you're using applanation. Now, when you're using applanation, the most important fact is to make sure that there is no compression of the cornea, that the alignment is right. So both these have to be factored in. So you can see the ultrasound, the applanation probe over there, and any compression of the cornea can change the axial length by up to around 0.1 to 0.3 millimeters, which means a huge change in the IOL power calculations that depend basically on only the applanation axial length and the keratometry values. So when you are using formulae that have lesser number of variables incorporated into them, that is when those variables get to be more significant. And that is when you need to make sure that the applanation you're doing is perfect. On the other hand, on the other side, you see the immersion being done using a parascleral shell. So here, compression of the cornea is completely ruled out because the probe rests in the saline solution or the lactogel or whatever viscous solution you're putting over the cornea. But still, alignment remains to be a question. The shell needs to be cornea centered, and the applanation probe needs to be kept perfectly vertical for the alignment to be good. And of course, the patient needs to be looking straight up. So all these are issues which creep into ultrasound biometry, but still it happens to be the mainstay in mature cataracts. Now, mature cataracts completely prohibit the entry of light into the eye. So where is the question of optical biometry? So in such situations, ultrasound biometry becomes the mainstay of the surgery because you can still allow a sound to pass through. Secondly, the patient is unable to fixate. So all those fixation parameters upon which the optical biometry is dependent on becomes redundant. So here it's just applanation that is going to help. Immersion would be the gold standard in such circumstances because they give pretty good values. Now, one thing I like to emphasize here is that all the values that you get using immersion, it would be better to use the same biometer to take a printout of the lens values using the formulae incorporated in that biometer to get the results, rather than transfer all these to an optical biometer, which has not taken the readings, and then get a lens value confirmation. So now here I have an applanation biometer, an ultrasound biometer, the killer basically. So here you can see that all the modern biometers not only give you the axial lengths, you can note that the axial lengths are pretty accurate, varying by only 0.01 to 0.02 millimeters. But it also gives the anterior chamber depth, the lens thickness, the corneal diameters, and it has on the left side, you can see various formulae incorporated into it, though not the very latest. But it does have a range which used to be accepted for the normal range of axial length, for the myopic axial lengths, and for the hypermetropic axial lengths traditionally. So all these are incorporated, and what you need to look at are the spikes that are produced by the cornea, the anterior and posterior lenticular surfaces, and the sharp spike of the retinochoroidal complex. So, and the gain, of course, has to be kept at the lowest by which you can get these very good spikes. So when you are completely tuned to that, you do get the values thrown up, the axial lengths thrown up by the biometer are very accurate. They vary minimally, as you can see in this picture, and you are sure that you are getting the right lens. So now, where are the discrepancies that creep in? So here, I'd like to highlight some situations where you're in doubt. I mean, was there a human error in performing the biometry? Or was there an error from the machine side? I mean, was the alignment correct? Or was the fixation out of order? So what are the discrepancies that can possibly creep in when you are doing biometry? So now here you have three charts. The two on the left are from the immersion ultrasound biometer, and the one on the right is from an optical biometer. which uses the optical low coherence reflectometry. Basically, the lens star is what we are looking at there. So now you see that the first chart on the left has thrown up a power of around 22.7 to 23 diopters, which is approximately 1.5 to 2 diopters away from what the optical biometer has thrown out. That is 25 diopters. If you look at the axial lengths carefully, I'll just take my mouse, the pointer over there. You can see that the axial lengths given are the same in all these. So it's an average of 22.4 in the ultrasound and 22.04 in the ultrasound and 22.05 in the optical biometry. So it is not the axial lengths that are different. And if you look at the K values also, it's not there in the ultrasound biometry, but they are also the same, an average of around 44.5 to 45 diopters. So you can see that the parameters measured are perfect. So now why this discrepancy in the three charts? Why is the second chart more in alignment with the optical biometer? So if you look at the formula that is being used in the two charts, you can see that the traditional SRK2 has been used in the first one and the Hoffer Q in the second. The Hoffer Q happens to throw up a more reliable lens power, basically because we are dealing with a short axial length of 22.0604 millimeters. Now, 22 to 20 millimeters is the optimum length at which the Hoffer Q throws up much more predictable values than the more redundant SRK2. That is why this corresponds better with the Barrett Universal 2 that is being used by the lens star. You can see that the Barrett is being used by the lens star, and it corresponds to a value, the 25.12 thrown up here, or the 24.39 thrown up here is much closer to the values predicted by the optical ultrasound. So here it is not a question of axial length measurement or keratometry. It's not a question of the instrument, but the formula that the surgeon chooses to use to predict the intraocular lens power. Now, this is a question I like to throw up. Basically, you have immersion on the left. This is from the Sonomed, not the Kila. And you have the, again, the optical biometer on the right. So you can see how different the power calculation is. One gives you either a 10.5 depending on the formula that you're using. So the regression formula gives you a 12.5. The holiday gives you a 10.5, whereas the optical gives you a 13.5. So here again, you're in doubt, what are you going to choose? Now, if you carefully look at the axial lengths, you can see that they are grossly different. The immersion is giving an axial length of 26.05 millimeters, whereas the lens star gives you a value of 25.21. So here there are better fixation targets in the lens star, and I always go for the optical value. Even though the immersion is considered gold standard, I'll go for the optical value because we are comparing a broad sound beam to a very narrow light beam, which is to the tune of 8 orders more precise than the light beam. And so for this myopic patient, I'd stick to a lens that keeps the patient myopic rather than hypermetropic and very unhappy. Now, compare the two immersion biometers here. So you see that here you have the Sonomed and there is the Kila. So you would expect that all readings from both biometers be in the same, virtually in the same region. But you can see that it is not. The axial length calculated by one is 22.27 over here, as the other is 21.99. So there is a 0.3 millimeter difference between the two biometers. Is either one of them wrong? No, it could happen because of alignment that, you know, the one biometer calculated a bit less than the other. It could have been because of compression of the cornea. So all these factors come into play, which gives you an approximately 1.5 to 2 diopter difference between the IOL powers calculated. So it's in the range of 20 over here, 19.5 to 20 over here, and 22 over there. So these are the discrepancies that we are trying to avoid when we transition to a more reliable biometer, especially in cases where young patients are undergoing the surgery, or when you have patients that are post-refractive surgery candidates, or you have patients that don't have a very dense cataract and therefore a very low vision, but are there for symptomatic purposes like glare or inability to drive and things like that. Basically, biometry is a sum total of all the basic values of keratometry, the axial length calculation, and also the path used, wherein all these factors are incorporated to reach the final intraocular power calculation. And this path should not be forgotten, is something that I'd like to stress on. So optical biometry. Now, what are we comparing basically? We are comparing light and sound. We know that the ultrasound probe has a frequency of 10 megahertz compared to partial coherence interferometry or optical low reflectance, low coherence reflectometry device, which has 8 times higher resolution compared to an ultrasound scan. So you have a 480 micron infrared light and an 820 nanometer diode in the OLCR. So these are the things we are comparing to the ultrasound probe. Now, of course, the swept source OCT has come in for the past 2 years, and you have slightly longer wavelengths, but these longer wavelengths ensure deeper penetration. They are as precise and they ensure deeper penetration so that you get better values. And you also are able to picture the fovea in some of the cases. You are able to get an anterior OCT in some of the cases so that you get the true shape of the anterior and posterior corneal surfaces. So the take-home message is that the accuracy is 0.012 millimeters in the optical biometer compared to 0.12 millimeters in the ultrasound biometer. Second aspect is what part of the eye, anteroposterior diameter of the eye, are you trying to measure? So basically, the ultrasound biometer takes up the theoretical optical axis, and the optical biometer takes the visual axis all the way to the fovea. Now, this is ensured by the various fixation mechanisms that are present in the optical biometer, namely the pupil tracking, the iris registration, the limbal vessels. So all these ensure that the fixation of the patient is consistent through each of the measurements taken, and measurements are taken much faster. Last but not the least, the ultrasound biometer measures up to the internal limiting membrane, and then it adds a default value of 200 microns to the axial length to compensate for the retinochoroidal complex. Whereas the optical biometer measures all the way up to the photoreceptor. So if you have an atrophic retina, which is less than 200, let's say 150 or 140 microns, or an edematous retina, which is around 400 microns, all these are going to produce significant errors in the axial length calculation in an ultrasound biometer versus an optical biometer. So what are the methods of biometry in the optical zone? So you have partial coherence interferometry, which has been there from the late 90s, early 2000. 2001 was when the IOL Master 500 was released, and it uses 780 nanometer infrared diode, 0.02 millimeters of resolution, measures axial length, the lens thickness, the corneal curvatures, the white, the anterior chamber depth. Then you have the optical low coherence reflectometry. Now this is what is used by the Lenstar and a couple of other devices basically. So it has an 820 nanometer superluminescent diode, and the structural reflections from the measured eye, they are superimposed on the reference reflections that are present. And this difference is what is reflected in the various parameters thrown up by the biometer, namely the central corneal thickness, the anterior chamber depth, the lens thickness, the axial length, everything. The swept source OCT is relatively new, but it has been incorporated in multiple devices. You have the new IOL Master 700 having it. Then there is the Argos, the Anterion, you have the Tomy, One of the Tomy devices has this. So now here it uses a laser of variable wavelength and obtains multiple B scans. So you have either combined a single refractive index that is used as in the IOL Master 700 or a segmental refraction depending on the media that the light is passing through. That is used to calculate the various parameters. The anterion is basically an anterior segment OCT along with deeper penetration because of the longer wavelength, therefore allowing measurements true of the corneal back surface as well as the axial length and the angles. Now that was regarding the axial length. So what about the corneal measurements? Because the corneal measurements are equally important, and any discrepancy of around 0.75 to 1 diopter in the keratometry values is going to produce an equal discrepancy of around 1 diopters in the lens power calculation. So the corneal measurements are basically done in 3 ways. The Simke assumptions are the historical method that is used where the radius of the anterior corneal curvature is converted to a dioptric power. Now it has a couple of assumptions that are incorporated in keratometers that use the Simke. One is that we are dealing with a medium of a uniform refractive index of 1.3375 diopters, 1.3375 units. Now, though we are passing through the cornea and the entire media which have varying varying refractive indices, including inside the cornea where the stroma is different from the Bowman's membrane or the deeper layers. It also assumes that the anterior posterior ratio of the cornea is a uniform curvature all throughout. Now, this is a factor which comes into dispute when you're dealing with patients who have undergone refractive surgery, because definitely the anterior corneal curvature has been changed with respect to the posterior corneal curvature, and that is where this assumption fails. Also, it assumes that the uniform corneal thickness of 500 micron exists throughout the area of measurements. Now, when there is a change in the anteroposterior corneal ratio, you have an overestimation of the actual corneal power measurement, which brings about errors in IOL power calculation. Gaussian optics is another method that uses thick lens formulae, but it basically uses the paraxial rays rather than the axial ones. And it gives slightly underestimated corneal power compared to other devices. Ray tracing is the way to go. Ray tracing actually passes an optical beam through the cornea, so it takes accurate values both from the anterior and posterior corneal surfaces. So this is the same thing that is incorporated in the pentacam in the form of total corneal refractive power, or the Sirius in the form of the mean pupillary power, the Galilei in the form of the total corneal power. It's also used in various software programs like the Oculix, which uses ray tracing to calculate the ultimate IOL power. So ray tracing is the most accurate way of calculating the corneal curvatures. Now, this is another case. Now here I'm going to show a couple of cases that we have used biometry on and why we intended to choose one over the other. So now here, this is a patient who had Fuchs dystrophy, and we're planning a DMEC along with a cataract extraction with intraocular lens implantation. You can see how there is epithelial edema and the stroma is also swollen up. That is the ASOCT picture from the anterior, and you can see the absolute absence of cells on the specular picture. Now here are the various scans done on the patient. So you have 2 optical scans here. Now, so here we are not, competing or making the ultrasound compete with the optical. So these are 2 optical scans done on 2 days. And you can see how in one you have, you can see that the axial lengths are the same, 23.97 both the scans. But how the keratometry values are entirely different. So you have an average of around 43.5 over here and an average of 45 over there. Now, such a vast discrete, so you don't know which keratometry values to accept. So you have a 17 intraocular lens power and 19.5 on this side. So which is the one you're going to choose? Because the axial lengths are the same. So the patient was well aligned. She was fixating well, and it's the keratometry values that have been thrown up by the same instrument as entirely different. So in such cases, we'd rather rely on a pure topographer. And you can see the topography values that are shown up here. And you can see how the anterior segment OCT and the ray tracing used for corneal measurements also throws up values which are very similar to the topography values here. So in the anterior, the steeper K is written first and the flatter K next. So that is why you have the values the other way around. And you can see that using that, you get an IL power calculation of around 18.5 diopters for the lens that she had chosen. And that was the lens. Agreed that it is a median between the 17 thrown up on one day and the 20 thrown up on another day. But here you have a biometer which is giving you exactly that value. So I choose that over the others. Now, how has this improved the functionality? You're getting vector fixation, like I have said before, and therefore an increased speed of acquisition. So older patients or patients who have tremors and those who are not able to maintain the position for a long time, they get much better. You get much better values in them. The tear film errors, because the constant opening of the eyes, are much less. And denser cataracts are penetrated better, especially with the modern swept source OCT instruments. You have only a very few percentage of people that cannot be measured. And the actual total corneal power is measured and not an assumed value as is done by the SIMK. Besides the integrated OCT present in some of these newer devices, make sure that the fovea is used for fixation. So there you have a picture of the fovea that is thrown up when the biometry is done, which makes sure that the light ray is going exactly to the fovea. Also, that same picture can throw up a DME if it's present, or a CSR it's present, that can lead to inaccurate values, and also tell the ophthalmologist that actually this patient may not get the predicted vision had the retina been normal. So it actually gives you an indirect information on retinal pathology. Now, what are the formulae that are incorporated? So this is one of the most important aspect I think we should be looking at, because there are still surgeons who would follow only the SRKT formula for all their calculations, which is very, very redundant. So I had recently been a part of a biometry program of the Cornea, the Kerato Refractive Society. And there they had actually highlighted how false SRKT values can be in biometry. So please understand that SRKT is not the gold standard. SRK2 is not the gold standard. It's better if you shift, and better and wise if you shift to the Barrett Universal 2. You don't need to have a biometer that has the Barrett Universal 2. You can go to the APCRS or the ACRS website where these formulae are given free of charge, and you can use your values, use it in them, and get accurate power reflections. The Holiday 2 uses more variables than the Barrett Universal 2. The Barrett Universal 2 uses 5 variables. The Holiday 2 uses 7 variables. Now, all these are better suited when the parameters drawn are from an optical biometer, because that is how they have been programmed. And they give a larger data for the effective lens position calculation. So effective lens position has become the key word in all these formulae. You're predicting a lens position, and that gives the best value for optimized refraction at the end of surgery. Then, of course, there are a lot of artificial intelligence formulae like the Hill RBF. That is also available free of charge. And though it has certain inbounds and out of bounds values, but it is basically a mathematical formula that uses computer learning to improvise itself. So the more data that has gone into the computer, the better values it churns out. Or the LEDAS super formulae that uses a couple of other formulae. The other new formulae like the Kane formula, that is a combination of theoretical as well as artificial intelligence parameters. So all these are things that we should be looking at. If you want me to choose one formula, that is the Barrett Universal 2 as of now, for whatever be the range of axial length we are talking about, myopic, hypermetropic, post-refractive, or others. Now, I'd again like to come to certain situations like toric calculations. Now, toric calculations are usually done by a toric calculator provided by the company, but all the modern biometers incorporate toric calculations into themselves. And whatever the toric lens you're using, whether it be from Alcon or from AMO, it does throw up the calculation, giving you the toricity of the IOL. As you can see over here, it's asking you to put a T6 IOL in the left eye and the axis that this should be aligned at, which is 165 degrees. So here you don't need a separate toric calculator. This is present in the biometer itself. That is one major advantage and enhancement from the previous generations. Another is when you're using a special situation. For example, here you have a young patient who has anisometropia. So she's myopic in the left eye, and she has always had good vision. She has a cataract in the left eye and she's come for surgery. And you would like to give her as good a vision as she had with her glasses before the cataract. So here you can see that on one day, you have a scan which gives you an 8 diopter lens. On another day, you have an 8.5 diopter lens. Suppose I wouldn't be able to take another scan, then I'd be going with a lens that gives me a higher myopic value because she was a myope preoperatively and she would be happier with this lens. But I do an anterion on her and I do get a value that is more than 8. So I again stick to the 8.5 diopter lens. So these are the small things that are helped when you do multiple biometry on different instruments. You don't need to have multiple instruments also. You can take that away from that. But if you do it on different days, please don't settle for a one-day biometry. Don't think about inconveniencing the patient. That's not the question. Optimum refraction is the question, and for which it's better to do multiple biometries, not on the same day. Better do the keratometry as a first procedure because you don't want the cornea to dry up and to get false values, but please do multiple biometries. Now, this is another patient post-refractive surgery. So you can see I have two optical biometry readings. One is a 10.5 diopter lens, another is a 9.5 diopter lens. And then I have an immersion value over here, which gives me a totally different 8 diopter lens. So now here, the question is not which biometer is accurate. It's a post-refractive patient, so I have to be very careful regarding the corneal readings that have been taken by these biometers. And though I have used one of the best formula available, like I mentioned earlier, the Barrett Universal 2, I'm getting different values. So in such a circumstance, I'll go to the much tested ACRS calculator. Now, the advantage of the ACRS calculator is that it uses many formulae. It uses a lot of parameters from different instruments, including historical values, and ultimately gives you an average power that can help you choose your intraocular lens. So here you can see that the average power thrown up by the ACRS calculator is 12.71 or 13 diopters, which is entirely different from what all my optical biometers were giving. So this was the power incorporated in the patient, and the patient has an uncorrected visual acuity of 6/9. He used a multifocal lens, so it was 6/9 N8, and 6/9 was the corrected visual acuity before the onset of cataract. Because it was my own patient, I could use the historical aspects of the parameters also into the calculator. So now these are situations where you cannot go by the time tested, you cannot go by the traditional formula, and maybe you have to use an enhanced calculator. So most of the studies that we have show that though ultrasound and optical biometers in most circumstances throw comparable values, there are special circumstances where the optical biometer may be preferred over the ultrasound. But of course, there are challenges where the ultrasound is preferred over the optical, especially in cases of mature, dense cataracts or in corneal opacities where light doesn't pass through, and in small children or debilitated patients or patients under anesthesia where the calculation has to be done under anesthesia. So in such circumstances, it is definitely the immersion ultrasound that is going to be of much value and would give you better IOL powers than an estimated optical biometric values. Of course, there is a role for the ORA in such circumstances where intraoperative aberrometry is used to calculate the IOL power. but it's an expensive instrument that's attached to the microscope. It has also been said to subject to intraocular pressure variations, giving variable powers under such circumstances. And you, of course, need to keep a whole range of intraocular lenses in your operation theater itself, so that whatever power is thrown up by the ORA, you can use that to fetch the lens. So that is another advancement that has come in intraocular power calculation. Now, as far as dense cataract is concerned, a heartening feature is that both the IOL master as well as the lens star has incorporated certain algorithms, because of which a lot of the dense cataracts can be overcome by these algorithms. Earlier, 8 to 21% couldn't be calculated, but the composite scan of IOL master, which uses multiple series of scans, has overcome 30% of these, so that and the composite algorithm of the lens star has overcome 71% of these. So the fraction of patients that are not able to undergo either of these optical scans has come down to less than 10%. Of course, the SWEP OCT with its deeper and better penetration has also reduced the number of patients who cannot give values with the optical biometer. So these are the changes that has happened over the years in biometry, from the time when, you added a plus 18.5 diopter to the preoperative refraction to get an intraocular power that was used way back in the 70s, to all these precise measurements and the surgeon mentality, where you are really, really sad if your patient has a 0.25 diopter of refractive error after the surgery. So all this has been made possible by the advancements in these methods of calculation, both methods of measurements and methods of calculations. Thank you. I hope that was a comprehensive view of biometry, both ultrasound and optical.
That was fantastic presentation. Let's see if there are any questions. Madam, can we incorporate Barrett Universal 2 formula in IOL Master 500?
I'm not sure about that, because it's definitely there in the 700, but IOL Master 500 didn't have it when I was using it. I'm not sure whether that software can be incorporated. Anyone?
Is it true that ultrasound biometer with calculation on advanced formula is equal to optical biometer? JP sir.
No, I won't agree to that, because I have seen patients that have had, if you take values from the ultrasound biometer, the way they are calculated are very different from how the optical biometer is taking these values. And when you put them into the optical biometer, I have done that for some dense cataracts actually as a part of a study. So we use values from the ultrasound and put them into the optical biometer to churn out values. And they have been quite off sometimes by 1 diopter, 2 diopters. Whereas if I use the same value from the immersion that I took it from, I use the printout of the immersion and the calculation that the immersion uses, I get much better refractive results compared to when incorporating in the calculator, optical calculator. I would like to know what other surgeons have experienced.
Can I make a comment on that? Rashobia.
Yeah,
Sure.
Yeah, the modern optical biometers, they have A constants that are optimized for optical biometry. So the reason why you are getting a different value in an optical biometer when you're entering the ultrasound values is probably because of the A constants and the difference in A constant. Otherwise, really, if the formula is the same, there shouldn't be much of a difference. And the other thing is that the A constants are constantly updated. So if you are not updating your optical biometer software regularly, what can happen is some of the A constants of the IOLs may be slightly outdated. Like many, we've seen that even in the IOL Master 700, the A constants for certain IOLs are not the same as the A constants or the lens factor that is shown in the online Barrett's Universal 2 calculator. So I think it's the best idea is to go for the online calculator to get the absolutely correct values. The online calculator, I think, is the final say because it has the most updated A constants and lens factors. That's my experience.
And many of the optical biometers give you an option for optimizing your own A constant. So if you have a series of cases and you have a targeted refraction and a refractive error, so you can enter all these values. So the IL Master does that, the IL Master 700 does that, the Lenstar does that, so that you ultimately get an A constant that is optimized to the surgeon, which gives much better results as far as the final refraction is concerned.
Actually, Dr. Barrett has recommended that for using the Barrett Universal 2, you need not personalize the constant. I mean, optimization that they have done already. You can just select the IOL from the drop-down list. The personalization of the A constant is actually not necessary for using the Barrett Universal 2. It is probably more relevant for the Hagues and other formulae.
Okay, that's...
And I had another question for you, ma'am.
Yeah, for sure.
For post-refractive surgery IOL calculation, in the ASCRS calculator, do you use the average of all IOL formulae, or is it better to just use the Barrett-Ruque? In my experience, I think the Barrett-Ruque gives the absolute bang-on value. I don't usually go for the average of all IOL formulae. Do you use the average?
You know what? Earlier, Barrett-Ruque did not exist. So Barrett-Ruque has come as a part of that suite that has been there for the past couple of years. But before that, ASCRS calculator, because it uses so many formulae, and I have found sometimes that the value given by the average of those formulae, because sometimes they're way off. So you get a whole range of values. So average given by those formulae, they are comparable to a Barrett Universal 2 formula. I'm not talking about the Ruque. Universal 2 formula, even in a post-refractive eye where you have got an optical scan, not by the ultrasound scan values. The one I showed you was entered from the ultrasound biometer because I was not getting any optical scan. It was a dense cataract. But if you have got a true optical scan, that corresponds well to the Universal 2 also. Plus, you can use values, keratometry values like the TCRP from the Pentacam, or the Holiday, you have the Holiday equation from EKR values from the Pentacam. So all these are highly precise. So I think from your experience, if you found that the Ruque is very good, it is, because there are studies that have shown it to be good also. But I usually take the average values because they have consistently produced only a minimal amount of astigmatism. I might have done around 20 to 25 post-refractive patients so far, but a minimal astigmatism as the end power rather than any plus or minus refractive.
I think Minu is there in the group. Minu, can you unmute and highlight something? Minu? No, he's not responding. Vinay is there? Jairam? They are all there, but not responding. Can unmute.
I think I'll ask a question on their behalf.
Okay.
Post keratoplasty eyes. How do you go about post PK or DALK eyes?
Yeah, that is a dicey one, because there I found that if you just do your regular biometry and then put in the value, the patient usually becomes hypermetropic. So DMAC, I don't have to adjust much. But if it is a post keratoplasty eye, then I go in for a topography rather than do the regular optical biometry calculations. And sometimes you get a range of values because of the irregular cornea. And in such circumstances, I take the whole range, and sometimes I have to do an averaging. So I may go for a higher intraocular lens power in these cases, so that the patient maybe by 1 diopter or so, or 1 to 1.25 diopter, so that the patient doesn't turn out to be hypermetropic after the calculation. So that is one thing I use. But there's an article, I think it was in the May 2020 issue of JCRS, where they have actually depicted on, rather it's post keratoconus eyes. on how to manage IOL power calculation post keratoconus.
I think in that article, if my memory is right, they've used the EKR values. I think
EKR values, yeah.
From 3 mm rather than 4.5 mm,
Yeah.
they use the 3 mm EKR values.
Right.
Again, some corneas we get vastly different values, so it's just a guesswork.
But what you have to remember is that light is going to pass through that center itself. So the closer you are to that, the better, though your cone may be at different places.
Dr. Minu, yes, online?
Yeah, yes, sir. Yes, sir.
What's your opinion on this?
Actually, sorry that I joined late. Do you have a specific question to ask, or should I comment, or what?
Swapna, what is that earlier question that for 500, what is it? I forgot the question. Let me go through. Can we incorporate Barrett Universal 2 formula in IOL Master 500?
No, that is not done by us. That is done by the company, and I think it is there only in 700 and 500. I don't know whether the company can add it for you. That has to be asked to Zeiss.
Okay, it's not something what we do it. It is
we cannot do it.
It is in the software. Andrew sir wants to ask something.
It's just a 5-minute job. You have to enter the value in the online calculator.
Yes, that is what, because you're already using an biometer, you can just enter the value in the online calculator.
Even though we have an IOL Master 700, I routinely enter it into the online calculator, because even with the latest updation, the lockdown and the latest updation may not have happened. So the online calculator, I think, is the best always.
Yeah, that's good. If you have a
yes, sir.
If you have an internet connected computer in your room itself, in your calculation room itself, it can be done immediately. So that is quite easily
on
possible.
the mobile, you can do it.
Yeah.
That's Andrew sir has just raised his hand.
Yeah, sir. Good morning, sir.
Unmute, sir.
No, he's unmuted. His mic is not working. We can't hear you, sir. No, it is
muted now.
Muted now. His mic is not working. Are there any more questions, Babu sir?
Andrew sir has put in a question. The chat.
In the chat. Okay, okay. Sorry, you can get it from there.
For general ophthalmology,
which keratometer and scan, which formula to use? The entire talk was for general ophthalmology.
So for general ophthalmologists, there is, I'd again suggest a keratometer incorporated with the biometer as the best way to go. But otherwise, I mean, it's not the keratometer as such which is going to give you wrong reading. It is a way of using the keratometer or the biometer, and in special circumstances, which value to take. So I wouldn't go to recommend any particular brand as such, but I would really advise that there should be a slight shift to
optical
biometry and better formulae that are available.
For immersion, which is the best formula?
Pardon?
So for any instrument you use, the optical is very difficult to buy for general ophthalmology. So many people. So an immersion biometry always, if done properly, it gives very close axial lens as you do it in an optical thing. And the keratometry is the one which is very crucial, as what has been mentioned. It has to be done on a fresh day. Without we should not general ophthalmologists should not rush into finishing all investigations on the same day when the patient comes and then get some aberrant value of keratometry and then get into trouble. So get a new value of keratometry, and this is available always. Barrett Universal 2 is available always everywhere. So internet, if it is available, then there is no need to identify an instrument which has that. So use your immersion and your good keratometry. Keratometry, even auto K gives a good value.
Exactly.
Topo also, we find that we get repeatedly. If you do, you get repeated new values. When patient came first, second, and third, and all, we have got repeatedly different values. So look at the eye of the patient, look for MGD, look for dry eye and other problems, and then calculate the keratometry properly, and then go to Barrett Universal 2. I think formula has to be Barrett Universal 2. No compromise on that.
Exactly. And each person, over the time, you can standardize your own method of doing it, and you find it is almost accurate throughout. What is called the surgeon's correction or something factor. Whatever method I had been following immersion for years together, I find it's quite comfortable for my except for very high myopes and all. It is a little difficult. Of course, I don't take up very high myopes, so it's not an issue for me. Okay, Babu sir, any questions?
Yes.
Anything?
Nothing. Very good, excellent, exhaustive study by Swapna.
Thank you.
Thank you, sir. Thank you so much. Mahesh, are you there?
Yeah, I am here.
Oh.
Mahesh, do you do biometry for all patients before doing your VR cases?
No.
No, we
actually,
here do.
Yeah,
you are doing for every patient.
Actually, once the silicone oil you put, the whole thing scenario changes. But luckily, in our case, we will never get 6 and all. So there is no complaint from the.
Anyway, but it is actually safe when you are doing all these investigations. What we feel is that when we doing all these investigations, we'll get a pre-surgical keratometry and everything done and a biometry done and keep. Later on also, we'll see how we can modify, how changes happen. But for the initial baseline, we get one done for all VR patients also.
It's a good system, actually. It's a good system. When we put oil, remove oil, we have to struggle to get the IOL power. But
that's a very good suggestion. That's an excellent suggestion. Actually, the person who's referring for vitreoretinal surgery, general ophthalmologist, just keep a record of this keratometer and axial length earlier. So that will be useful later. As a vitreoretinal surgeon, they are not bothered about that. They just keep doing it.
Yeah.
When they come back, we need some calculation to depend on.
Once maybe we also get a refractive surprise, like they get 6 or something, and with there is a residual power plus 2.
Getting 6 is a surprise.
No. Oil we will put only in PDR and RDs, where we don't expect that perfect vision unless.
A total vitrectomy, will it affect the IOL calculation formula?
I don't know.
Because some media is changing.
Again, that depends on, suppose you're using an SSOCT. Let's start with immersion. If you're using an immersion, there are some biometers that actually factor in the media refraction, the different speed of sound in different media. The cornea and the lens, it varies compared, it's 1641 compared to 1532 in the anterior chamber and the vitreous. So in such, you get much better. This is called segmental refraction. So you get better values. Similarly, some Swapsos OCTs, they like the Argos. It factors in the refractive index of each part of the media, and it's a segmented refraction that's happening. So that gives much better values compared to combined refractive index.
The worst scenario. The worst scenario is high myope, post LASIK, RD, oil, then oil removal and cataract surgery. That is the worst scenario we get. Always we struggle, and ultimately we take lot and then decide which IOL.
Yeah, again, we do biometry pre-LASIK in all patients. Pre-LASIK and any refractive procedure we do. Biometry we routinely do.
In same place it is fine. Otherwise, some patient is coming from some 10 years back. He had some very difficult.
Yeah, because the message should go.
Yes, sir.
The message should go to everybody to have a calculation done and give it to the patient itself and ask them to keep it for later use when they go for further procedures. So general ophthalmologists, everybody should have that in mind, that first do it and give it to patient, to ask them to keep it.
I think the significance is basically in the K values, which is invariably done as a part of LASIK. Because we don't expect a change in the axial length or change in the lens thickness or any other parameter, other than the CCT perhaps.
But that include that in the patient's discharge card or whatever, so that they can keep it. Later on, they will be struggling to find out what it is.
Correct. Now that number of people with complications are increasing as the time goes up. No? Right.
Okay. Are there any more questions? You can unmute and ask in the group or in the YouTube. Any questions? No, I don't think there are any more questions. A few concluding words, Mahesh.
Yeah. Okay. Actually, there are senior
Secretary.
refractive surgeons.
Secretary has to say the concluding.
Anyway, this thank you, Swapna, for that.
Unmute.
YouTube for a long time. Anybody can refer to it, and we will. The hit will gradually increase over the next few days. That people viewing this. Thank you, Swapna, and thank you, Rajiv.
Thank you. Thank you, Swapna.
Thank you for giving me the opportunity to present. Thank you, sir.
Thank you so much.
Thank you.